Okay. Very good evening to all the doctors across India. I am Dr. Kapil Dev Mehta from JB Pharma, and I accord all the welcome to all the delegates attending this program virtually. I would also like to welcome all the esteemed faculty members who are present here today for this meeting. So, doctors, on occasion of National Lipid Day, JB Pharma, in association with Familial Hypercholesteremia Research Foundation, has organized an expert talk on clinical practice guidelines on dyslipidemia management, what we have learned so far. So today we have experts who will throw light on the current challenges in management of dyslipidemia and what the guidelines say for the management of dyslipidemia in India. So I would like to introduce all the faculty members. Firstly, I would like to introduce our speaker and moderator for today's event, Professor Dr. JPS Sani. He is Senior President of FHRF, Chairman, Department of Cardiology, Sir Gangaram Hospital, Delhi. So welcome for this program. I would also like to introduce all the elite panel members of this panel discussion. So first, I would like to introduce Professor Dr. Krishna Kumar. He is Secretary FHRF and Senior Interventional Cardiologist at CMC Kochi, Kerala. Also, next, I would like to introduce Professor Dr. Soumitra Ray. He is an executive member of FHRF and also Director of Invasive Cardiology at AMRI, Kolkata, India. And we also have with us Professor Dr. Ashwini Mehta. He is a senior consultant at Gangaram Hospitals, and he's also an executive member of FHRF. Just I will give a brief about the agenda. Today, we will have a talk by Dr. JPS Sani, sir. And after that, we will have a panel discussion with the eminent panelist. With this short intro, I now hand over the session to Dr. Krishna Kumar, sir, for setting the context for this meeting. So over to you.
Thank you, Dr. Kapil. I think on celebrating the National Lipid Day, because we are presenting our Society of the Research Foundation, FHRF, that is Familial Hypercholesteremia Research Foundation, is organizing a webinar on the sidelines of the first ever Cardiological Society of India lipid clinical practical guidelines. Why it is so important? Because in India, like in so many other developing countries, even in developed countries, the control of dyslipidemia is abysmally very low, very, very low. And at the end of 1 year following a heart attack or any secondary prevention thing, the usage of statin is still very low. I think less than 10% or less than 20%. So in this context, because I think 2023 last quarter, the Indian Heart Journal has, with the main stewardship of Dr. JPS Sani and the other two panelists, Soumitra Ray and Ashwini Mehta, they were also the writers along with Dr. JPS Sani in this guideline. So the CSI has formulated the first ever clinical practical guidelines that emphasizes the 4 dictums. That is, the earlier, the lower, the better, the earlier, the better, the longer, the better, and together, the better. So that is the motto of our CSI practical guidelines, and that should be inculcated in the minds and hearts of every practitioner, healthcare practitioner in India, even if it's a primary care practitioner or a diabetologist or a physician or a cardiologist or an endocrinologist. Each and every doctor in India should be able to get an assimilation of the key highlights of the practical guidelines. Without much wasting the time, I would like to invite Dr. JPS Sani, the chairman of the lipid guidance for subspecialty of the CSI guidelines, for the inaugural expert talk. Thank you.
Thank you, Dr. Kishan Kumar, for giving me this opportunity to give a talk on this important National Lipid Day. And as you rightly said, that we are for the first time having a guidelines from this Cardiology Society of India which is a clinical practice guidelines for the management of dyslipidemia in India. So what this guideline, in fact, I must tell you the little bit of the
Recording in
background.
progress.
That we took almost more than 3 years, 3.5 to 4 years to prepare this manuscript, which was finally was published in the Indian Heart Journal supplement issue. And we 22 cardiologists all over the country, and we have contributed 24 chapters in this guideline. And this was the hard work of all my colleagues. I'm thankful to them for preparing this practical guideline. This was the executive summary in our manuscript. We have also have the uh, uh, a executive summary also. The whole manuscript is 140 pages, but 14 pages are devoted to the executive summary. So it became a ready reckoner for physicians to use in clinical practice. So what was the need for this guideline? So what we started looking into our country, are we different? So far, we had only consensus statement came from our colleagues and also from CSA in the past, but that was based on only expert opinion. So we started looking into the data of our country. So we looked into that. Why is there any need? Why there is a need for our separate guideline? So what we found that cardiovascular disease comes almost 10 years earlier in our country, and more than 50% of the people are less than 50 years of age. 50 to 20% people are less than 40 years of age. And that was one of the reasons why the international atherosclerotic cardiovascular calculators, like Framingham calculator or SCORE or JBS, they did not identify right patient from our country. So because most of them are young people, and that's why we were under diagnosed or underscored in those risk calculators. So in view of that, we decided not to use calculator in our guideline. We only use the risk factors. The other thing what we found was, are we accumulating this risk factor earlier? Or do we have a risk factor which are a little different from rest of the world? Yes, hypertension and diabetes, we are getting it earlier in our group. The smoking is there, but the chewing tobacco and BD smoking is unique to our country. Central obesity, what we say truncal obesity, has been found to be much more common in our country compared to the Western world, almost double. And because of that reason, and because of many other reasons, we also have a unique dyslipidemia, what we say atherogenic dyslipidemia, high triglyceride, low HDL cholesterol, and high levels of small, dense LDL cholesterol. Then we started looking at our own data over last 7 to 8 years we accumulated and found that genetic causes are also much more common in our country compared to the Western world. Familial hypercholesterolemia has been found to be there in young coronary artery disease patients. Those who are less than 50 years, they are 50%, is more than 15%. In fact, the recent data shows it is 17%. Lipoprotein A, which is the greatest risk marker now, what we have identified associated with increased cardiovascular events, again found to be much higher in our population compared to the Western world. Then we looked into the lifestyle factors of our country. Sedentary lifestyle is highly prevalent. Unhealthy cooking, dietary patterns, like we have a significant number of people taking high carbohydrate diet because of vegetarianism, and high carbohydrate diet is directly related to atherogenic dyslipidemia. So these were the various factors which we found they were unique to our country, and we should have our own guideline. So what we decided that all of us, that for the first time, the guidelines is customized to Indian population because this is mainly based on Indian population. Although we concede that in many instances, hardcore Indian data was not available, we had to tweak in the international guideline of ESC 2019. Now, this is the guideline of ESC 2019. It is widely accepted globally by the International Lipid Expert Panel also. And so that was one aspect. This other thing was the certain area, the experts' opinion of the combined vast experience of all the cardiologists in this field, those who are working, was also taken. But we have a good data from our country on epidemiology, on clinical trials where we have participated, and also genetic studies. And in some areas, small number of patients, and how we are behaving with statin and non-statin drugs. So I just discussed that because we do not have our own risk calculator, so we avoided that and used only risk factors. So I believe that probably this is the first attempt at the moment at India's centric clinical practice guidelines, which will be updated every 2 years by us, depending upon the new data which comes to available to us. So let me start with the epidemiology. This is the data which published by Dr. Mohan and group and in Lancet June 2023, showing that hypertension is there in 35% population, diabetes 11.5%, and the dyslipidemia has 82% of patients, mainly driven by low HDL cholesterol. This is the data on 113,000 individuals, both from the rural and urban areas. At that time, they took the LDL cholesterol above 130 as abnormal. And we can see here, there was a wide variation between interstate and interregional variability, what we can see with highest prevalence coming in northern region, Kerala and Goa, and also to some extent in West Bengal. The high cholesterol level, and similarly, high LDL cholesterol was same. So we found that around 185 million have high LDL cholesterol if the levels are above 130. But when we look into our own data, it probably is much more. It is more than 300 million now. On the other hand, you look at the triglyceride level, almost whole country is red. And similarly, the low HDL cholesterol was similarly behaving. And there was not much of difference between urban and rural areas, and also not much of difference between interstate and interregional variability, unlike the LDL cholesterol. That was showing that there is a significant prevalence of atherogenic dyslipidemia in our country, and so also the central obesity. This data by Dr. Rajiv Gupta on the from the urban area, Jaipur Watch study, and they found if the 100 milligram is a cutoff, then roughly 50% of the population in our country are suffering from dyslipidemia because of high LDL cholesterol. Since there was high atherogenic dyslipidemia, we started looking into non-HDL, and it is more than 55% of the general population. It's a big number. So more than 350 million people are suffering from dyslipidemia in our country if you look at only LDL cholesterol. Otherwise, 82% of the total population is suffering from dyslipidemia if you look at the TG and low HDL cholesterol also. So with this basis of that, we have such type of prevalence. So this was the first prevalence data which came. And based on this, an expert opinion. And so we took the base of the guideline was basically similar to that of ESC 2019. So we did not make much of difference, but we found certain areas we made some amendment or some changes in our guideline based on our population. One was that since there was an increased evidence of atherogenic dyslipidemia, so we decided to not only to look at LDL cholesterol, but for a stable patient, also to look for non-HDL cholesterol, which is just 30 milligram more than that of the LDL cholesterol, because large number of patients, they reach actually LDL cholesterol, but yet their non-HDL cholesterol is high, and we have to intensify the statin doses in those patients. Secondly, an extremely high-risk population were the one when getting recurrent coronary events within 2 years in same territory or other territory of polyvascular disease. That was considered as an extremely high-risk population. And our study of 4 years, we found there is another group, that those who are suffering from atherosclerotic cardiovascular disease and having FH, they have young people with atherosclerotic cardiovascular disease and having associated elevated LPA. So two genetic factors, if they are there in a young patient of CAD, he is also belongs to extremely high risk population. And there we suggested to keep it below 40, going up to 30 or 20 is also okay. And non-HDL at 70. Very high risk population is the same, and any atherosclerotic cardiovascular disease, imaging more than 2, visible more than 50%, diabetes, FH patient, and CKD patient, they will not change much. In high risk population, yes, we made addition that besides the diabetes with risk factor, HF patient, familial hypercholesterolemia patient with no risk factor, but in hypertension with one risk factor or hypertension with target organ damage, we decided to keep them into high-risk population, just like diabetes, and suggested to keep the LDL cholesterol less than 70. So this was a new addition, which was a little different from the ESC guideline. Whereas moderate risk and low risk population, single risk factor, no other risk factor, or no risk factor, we decided to keep it below 100, unlike 115 given by the ESC guideline. The second area, which is a common problem which we face, is acute coronary syndrome. And in that situation, we found that we have suggested to do a non-fasting lipid profile for every patient who enters into the hospital or nursing home for management, along with the other biochemical tests, and should be given treatment with the aim of hit hard and hit early, because our aim is to prevent recurrent coronary events, which are very high in this population, up to the tune of 10 to 15%, and to bring the LDL cholesterol below 55 as soon as possible. So we rely on our two studies in our country in small number of patients. We look into the lipid profile of patient at day 0, 7, 14, 28, and 42 in similar patient on 400 patient. And if we found the peak action of statin comes at 4 weeks, not 6 weeks, at 4 weeks. Beyond 4 weeks, there is no further reduction of LDL cholesterol. So we decided to hit hard by giving 40 milligram of Rosuvas or 80 milligram atorva along with azithromycin 10 milligram, so that we reach the goal of less than 55 as soon as possible. And if it is not reached in 4 weeks, we should add bempedoic acid. If still not reached by 8 weeks, then adding PCSK9. And now we have inclisiran available to us also. This drug has the advantage that it has to be given only twice a year against 26 injection, and it do not cause LDL variability, and it seems to be cost effective. So we found that if you adopt this approach, then almost 100% of the patient will reach the goal of 55 and below in this, except that the situation is the injectable drugs, PCSK9 and incretin, are costly drugs. At the same time, we have decided that if a patient is above 75 or CKD 3 to 5, then we should not give them 40 or 80, we should give them 20 and 40 of Resuvas atorva along with HTML. Now, after 3 months, there was what we have a data from our country looking into the adherence therapy. We found many patients are on lower doses of statin. So what we decided that there should be a logical way of reducing or down titrating the drug. So for that, we decided that if a patient has SAMS, the statin associated muscle symptom, which can happen in 10% of the patient or maybe more if you are in high dose of statin, then we decided to down titrate it from Rosuvas 40 to 20 or atorva 80 to 40. Second group was one whose HbA1c was normal or a pre-diabetic state, and it is showing a rising trend after 3 months. Then in that, if you're getting a new onset of diabetes, probably reducing the dose of statin will be a good idea, but repeat the lipid profile again after 4 weeks, even after reducing the dose. If the levels are still below 55, we continue with the lower dose of the high-intensity statin. But if the levels are not reached below 55, they are above 55 with reducing the dose, then add bempedoic acid. So this is the way we thought we should approach a practical way of managing the dyslipidemia. The new addition in this study, in this guideline, was a management of stable coronary artery disease or stable stroke patient. Here, again, there is a patient who come to our clinic is a big number of population where fasting, non-fasting lipid profile is good enough. Here, again, we decided to give them high dose of statin. Dose was 20 or atorva 40. If not reach the goal, then instead of doubling the dose, we decided to add HTML. So what we found in our experience of 4 years of data of our country, then majority of the patient with 20 Rosuva and 40 atorva along with HTML 10, that was based on Lodestar study also, have shown reaching the goal of LDL below 55 in significant number of patients more effectively and more safely, because the high dose of statin is not given here. It is the lower part of the high dose of statin. So we have less chances of myalgia, and also we have less chances of new onset of diabetes. So that was the approach we decided in our country. Then came to the another aspect of lipids, that is the hypertriglyceridemia. There was a question whether to treat this or not. Yes, we have to treat it. Earlier guideline used to say that you empirically, that if about TG is about 200 milligram, look for non-HDL. We decided no, that above 150 TG, look for non-HDL cholesterol, which is nothing, total cholesterol minus the HDL cholesterol in non-fasting state, it will not be affected. So if the levels are high, if a patient is diabetic or hypothyroid, correct those two conditions, and still TG is high, then use the lifestyle modification, reducing carbohydrate diet, fatty fatty diet, the alcohol abstinence, the tobacco cessation, physical activity, weight reduction. I think with this measure, significant number of patients, triglyceride will come down to less than 150. You don't need to add any drug. But yes, there are patients, in spite of everything, the levels are still above 150 but below 500, and they are having atherosclerotic cardiovascular disease, or they are having diabetes with respect to here. Along with the lifestyle, we have to use statin and non-statin drugs to reach the goal. If it is not there, then adding non-statin drug like IPE, eucopentyl ethinyl, which is IE, is a good drug to be added. But if the levels are above 500, and here the prevention of pancreatitis is there, whereas the level up to 500, atherosclerosis prevention is because of the remnant cholesterol which is present in the cholesterol, like IDL, VLDL cholesterol, or small chylomicron. Whereas if the triglyceride is above 500, it is the large size of chylomicrons, which plugs the pancreatic vessel and causes pancreatitis, a third common cause after gallstones.
I think Dr. JPS Sani has lost this. Dr. Kapil?
I think he has lost his connectivity. I think let us check with him.
Dr. Saumitra?
Yes, I'm here.
Yeah. Can you come on? Can you discuss the role of fibrates in this treatment of hypertriglyceridemia in connection with this thing?
Yeah.
Guidelines?
Yes, as Dr. Sani was saying, that we in the CSI guideline has unambiguously said that triglyceride is important for atherosclerotic cardiovascular disease. There is no doubt anymore in 2024. And second, we also emphasize that it needs to be treated. That is also very important. Treatment does not necessarily mean pharmacotherapy, but it needs treatment. Now, depending on the initial level of triglyceride, we decide how to go about it. Everybody knows that if TG is more than 500, and TG has to be fasting. Now, that is very important. Not a random sample can very accurately set LDL, but for TG, we need a fasting lipid profile. If it is more than 500, the immediate risk is, of course, pancreatitis. And we need to very aggressively control the diet and stop the secondary factors like alcohol, uncontrolled diabetes, uncontrolled thyroid disease immediately, and to start fibrate, because that is the most time-tested and effective medicine, and or saroglitazar, which is unique to India, because saroglitazar is almost as effective biochemically as fibrate, and they can be co-administered. That is the beauty of it. They can be co-administered, and plus minus omega-3 fatty acid. And if it is not below 500 still, then we have got certain newer drugs like evenocumab, angiopoietin-like protein 3 inhibitor, etc.
Doctor, let me interrupt you because Soumitra, as a primary care physician or a healthcare diabetologist or a physician, so most of these people are coming with a 150, 160, 170 or 200.
I'm just coming to that.
Describe this thing.
So absolutely. So that is our business day to day, which we the cardiologist or metabolic physician see. We don't see so much above 500. So we say between 150 and 500, mostly around 200. So now here, there is no urgency. Firstly, we have to implement the lifestyle changes. As I have already mentioned, the diet, exercise, appropriate weight, and alcohol abstinence, smoking cessation, thyroid check, sugar check, nephrotic syndrome, liver function. These have to be first ruled out. Second, if still it remains above, and if we think the patient has got a CVD or diabetic with risk factor, then we need to start treatment. Now here the treatment is usually again statin, a high dose of statin, along with other anti-cholesterol drug, which reduce cholesterol by around 15 to 20%. Ezetimibe reduces cholesterol also. And if that is not sufficient, we add fibrate. We add
Recording in
fibrate at a
progress.
we add fibrate on a small dose. But if the patient has got no such ASCVD or complicated diabetes, then we can give lifestyle therapy a go for about 3 months. And then if it is still high, then we can think of a low dose fibrate to add with statin. But we have to be careful while we are adding fibrate with statin, because we have to check the renal function very frequently, because there can be some red box warning about the combination. Maybe saroglitazar is a better combination with statin because it has got a very good side effect profile. So I think, I think most of these patients can be managed with a good dose of statin and with saroglitazar or fibrate, which are very good. Omega-3 fatty acid is rarely needed in such patients, which are very expensive as well, with with some side effect like new onset atrial fibrillation, sudden cardiac death. So we try to avoid those. But very important, Dr. Sahani said that non-HDL is more important than LDL in such cases, because non-HDL captures the triglyceride-related lipoproteins, that is VLDL, IDL, and chylomicron. These three are dependent on the triglyceride levels. So in non-HDL, we captured these three lipoproteins as well, and it indirectly indicates that, yes, triglyceride is a problem in this patient. So we turn our focus to triglyceride.
Yeah, excellent, excellent synopsis of the role of fibrates in the management of diabetic dyslipidemia. So, Dr. Ashwini, so what is your experience with the saroglitazar in the management of this hypertriglyceridemia? Or still, are you using only fibrates as he has detailed?
Yeah. So, in fact, saroglitazar, what we have been using has been very great. And we've been quite happy using saroglitazar. And I have seen a very robust decline in triglycerides. Very, very robust decline.
Okay.
So, and I have been using it in combination and also in along with the fenofibrates, with statins, the triple combination also in some of the patients.
Okay. So, Dr. Soumitra? Dr. Soumitra?
Yes, please.
So you suggested that you will be more inclined to non-SDL estimation, means compared to the LDL in the case of a atherogenic dyslipidemia or a high triglyceride.
Yes.
So what will you be using ApoB if it is available in contrast to non-SDL?
Yes, ApoB is also very important parameter, but not yet very standardized. I know it is epidemiologically very robust, but we do not have very good cutoffs of ApoB as compared to LDL or non-HDL. But yes, ApoB actually even more sensitive because it is independent of the size of the molecule, because we ultimately know it is not the level of cholesterol, but the size of LDL particles. So if the size is small, they are more atherogenic. And for the same amount of LDL cholesterol, there will be more particle. And more particles means more atherosclerosis. So that actually is captured by ApoB, because ApoB is dependent on the LDL, the lipoprotein molecule number. So I think Dr. Sahani is back. So we should finish the lecture and then we will come back.
Okay. Thank you, Soumitra and Dr.
इधर कहाँ पर है ये आ नहीं रहा ये वाला
Yes, sir. You were in.
Yes, the Krishan Kumar, I am now ready.
Yeah. You can go ahead with me. Yeah. Very clear.
Yeah.
You hear me now? Okay. Fine.
So, can you see the slides also?
Yeah. Easily visible.
Okay.
Very clearly visible.
There was some problem about the. That's right. So we were discussing that the levels are above 1,000 or 1,500. Then we'll give fibrates have a role to play, and then omega-3 fatty acids, which we discussed already, and saroglitazar, we just know Dr. Ashwini was discussing, and diabetic population and patient with NAFLD or MEFLD, we should use saroglitazar, although there is no endpoint data available, but we have included in our guideline this drug. So that's how we should manage the triglyceride in clinical practice. So the other part is the genetic dyslipidemia in our country. We know that familial hypercholesterolemia, the heterozygous is quite common, and we have decided to put my family history, LDL cholesterol level, and presence or absence of arcus cornealis, which is a very important semicircular grayish deposit around the eye. Although the gold standard is the DNA mutation of LDLR, ApoB, and PCSK9, but this scoring system is very useful in clinical practice. And we have used that. If the score is 6 and above, we called it FH, and it is validated with the genetic testing now. And some patients are already on statin, then we have to have non-statin, statin naive LDL level. We have an adjustment factor available for all the cholesterol, anti-lowering, cholesterol-lowering drug along with their doses. So that we will, this is there already in our guidelines. But one most important thing is that the importance of diagnosing FH is not only to treat the index case, but to identify the family members, those who are carrier of this gene, by doing a cascade screening of non-fasting lipid profile of the children and brother and sister. And by diagnosing a case of FH, we do not identify a case, but a family at risk. So that is a big message. And in our own study, which we have published and which is the only study at the moment in Asia, where we found in young MI patient, definite and probable FH is in 17% of patients, is the data from more than 1,200 population. And we look into the associated risk factor in FH population and also the total cholesterol level. We found significant association of risk factor in the patient, those who are having possible FH or no FH in young MI. But those who are definite and probable FH, we found they have associated risk factor were less, but they had high cholesterol. So what we learned that if young patient comes to you in clinical practice with CAD, and if he has no diabetes, he is not a smoker, no significant risk factor, but little high cholesterol, even above 130, always suspect about FH and try to use Dutch lipid clinical criteria so that not only treat the index case, but also the family member. So this is the algorithm for FH, that young CAD applied Dutch lipid clinical criteria, score is above 6 or 6, it is FH, heterozygous, treat them with the high dose of statin, Rosuvastatin or Atorva 40 and 80, H-tamide, and even we may have to add bempedoic acid if the baseline LDL levels are very high. If it is still not reached the goal, then inclisiran or PCSK9 inhibitor are the drug to be used. But remember, the treatment is not complete unless and until we have done a cascade screening. And by doing cascade screening, we can pick up a lot many patients in the society, those who are asymptomatic, but carrier or FH. If we do not treat them with modest doses of statin and lifestyle modification, they all will get disease between 35 to 50 years as premature cardiovascular disease. So that is the importance of identifying FH, which unfortunately in our country is grossly underdiagnosed and undertreated. The other important risk factor, the genetic dyslipidemia, was lipoprotein little a. Levels above 50 milligram per deciliter is considered to be high. And in comparison to the rest of the world, we have much higher general population with high LPA. And in fact, this is the commonest genetic cause of dyslipidemia after and the second commonest is familial hypercholesterolemia. Almost 1.4 billion population is having high lipoprotein little a. And we have now data from the epidemiological genome-wide association and Mendelian randomization study showing that if you have LDL, LPA above 50 milligram, there is a 3 to 4-fold increase in myocardial infarction, aortic valve disease, ischemic stroke, heart failure, and cardiovascular mortality. Unfortunately, at the moment, there is no treatment for this. Statin, H-tamide, bempedoic acid do not have any effect on lowering the LPA, whereas the PCSK9 inhibitor or inclisiran can lower only by 25%. Specific drug therapy is going on now. The ASO, what we say, the pelacarsen in Horizon trial, Dr. Ashwini, we are in this trial, the study is going on. Results will come, I think, in early 26. The other drugs are olpasiran also
few more molecules are being evaluated because they reduce LPA by 80%. And probably that will result in reduction of cardiovascular event. So at this point of time, what we say, if you have a high LPA, then these are the patients, they have two things. One is that once in a lifetime, this should be done. And secondly, they have resistance to the statin drug treatment because the LDL present in LPA is the most atherogenic part of dyslipidemia, or causes more atherosclerosis. So what we have, that if a person has got high LPA, this is a magnifier. So if a person has LDL 100 with normal LPA, the other person has 100 LDL with high LPA, the 100 will behave like 130. So that's what we have learned now, but we are waiting for the drug to be available in the practice. So, and we did study on our country, which we have published in our guideline. This is the only study recently done in more than 1,000 patients of atherosclerotic cardiovascular disease. We look into their LPA level along with lipid profile, and we found great correlation that the high LPA was associated with young MI, and it was also associated with severe disease. And in our population, those who had FH and young MI, the associated high LPA was more than 40%. So general population is 25%, CAD is 35%, and FH is more than 40%. So that is the association of these two drugs. And we have a chart in our guideline of all the drugs, a very easy reckoner, a single chart of all the antilipidemic drugs, their doses, their side effects, how to use, contraindication is very good, ready reckoner for physicians. And we also a chart on the diet part, and we have for the first time discussed that the modest consumption of fat will not cause so much atherosclerosis. High consumption of carbohydrate food, sweetened sugary beverages, they cause much more cardiovascular disease and atherosclerosis compared to that of the modest consumption of fatty diet. And this is based on the pure study. So that is there in the full chapter written by Dr. Arun Chopra. And we have a good chapter also on young coronary artery disease, young patients with dyslipidemia, what should be done. So we have suggested that in our country, the lipid profile should be done first time at the age of 18. When a child goes from school to the college, he should get not only sugar tested, blood pressure tested, but also the lipid profile tested, because we get disease in early age and even in a lower cholesterol levels. And those patients, those who are having atherosclerotic cardiovascular disease, as we know in 20% of patients, their treatment do not differ between adults and young adults. Young adults having LDL above 190 should be treated with lifestyle and statin. Patient of young adult with LDL above 100 milligram with diabetes and hypertension should be treated with statin to bring the goal to less than 70. And patients, those who are the carrier of familial hypercholesterolemia, should be treated with the triglyceride management in young adult is not different from that of adult population. And finally, I would like to share with you that what we have learned in our countries, the lipid profile testing reports, which is available in 3 lakh laboratories in the country. Unfortunately, only 2,500 are NABL accredited. And we found there was so much variable in the, for example, LDL levels, we have variable from 40 to 130 or 80 to 130 like ranges. And we have now decided and given instruction or suggestion to our biochemist colleagues that they should have a uniform lipid profile report throughout the country in every lab. It should read like this, the way we have table have shown. The LDL below 100, non-HDL below 130, and triglyceride and lipoprotein below 50. And we have suggested that there should be asterisk marks over the report so that every individual should not think if a person has LDL below 100 like 90, but he's suffering from coronary artery disease, he should know that his level should be less than 55. And this is what we have suggested in this table, and we have given the what is low risk, moderate risk, very high risk, and high risk. So a person reads that, then he will automatically able to know that yes, he's a diabetic, hypertensive, having risk factors. Probably he has to keep it below 70. For him, below 100 is not normal. So this is the way we have tried to do that. So many other aspects which we have discussed about adherence. Dr. Ashwini written a very good chapter on adherence, and we found very, I would say, sad to know that after 1 year of ACS, only 20 to 25% patient are on high dose of statin, and majority of the patient they are having, or I would say, 70% of the patient their LDL is above 55. So, and one of the important reasons for that has been just a physician's inertia. The physician, they reduce the doses of statin for some reason which we don't know. Side effect plays a role, no doubt in that. Cost may be playing a role, media may be playing a role, but it is possibly the physician's role which is playing a major role. So even if they reduce the dose, they forget to repeat the lipid profile, and readjusting the doses is required. So dear friends, ladies and gentlemen, to conclude my talk, that for treating physician, this executive summary which we have given, it is for the, as Dr. Krishan Kumar said, it is by Indians on Indian population, and a specific study, which is a guideline specific for Indian population. We have tried to cover almost every aspect of the dyslipidemia management in this monogram, and we have produced that executive summary to be used, although majority of the guideline has some version of ESC guideline, but there are certain areas where we have changed our guideline according to our population. So our slogan for, as Dr. Krishan Kumar said in the beginning, that we should pick up disease early and treat them earlier, and we keep them lower as 55 or 40 or 30. That will always be better. It is safe and should keep it throughout the life. That is very important to reduce the atherosclerosis. And together, the better means that most of the patient probably will be requiring a combination of drug, of statin and non-statin, to come to the conclusion. So thank you very much to all of you, those who are attending the meeting, and also my colleagues, those who have participated in this study and my discussion formation. Thank you. Over to Dr. Kishan Kumar. I've stopped sharing the slides.
So that was a nice comprehensive summary of the practical CSA lipid guidelines. I think we have some, because the time is running short, we have some audience questions. We will take the audience questions first.
Sir, Mana connect ho gaya.
Yeah. So, Dr. Ashwini, Dr. Soumitra, can you address this question? Yeah. So the first question is, why HSCRP testing is not a common practice in high-risk CV patients in India?
HSCRP is very variable. You know, any kind of inflammation in the body can raise the HSCRP. Like a simple tooth infection can cause a high rise of HSCRP. So to HSCRP to be clinically useful to predict atherosclerotic cardiovascular disease, you need the patient in a very basal state. And you have to exclude the patient is not having any infection or inflammation. So many a times, otherwise we get a false result and we give some false report as well. Secondly, HSCRP has been in epidemiological studies and also certain studies like Jupiter trial has been shown to be a risk marker, even sometimes even more robust than LDL cholesterol. But there is no such targeted treatment, no such graded threshold for different types of patients, is below 2, above 2, something like that. But we know that it is a spectrum of disease, and like LDL, like triglyceride, we have got a various threshold for various types of patients. For HSCRP, there is no such robust data that for which patient what should be the target, whether it is below 2 or above 2. Even if it is above 2, what to do about it? Give colchicine, giving high dose of aspirin. We are not very sure. Colchicine has got dubious result, you know. There is no mortality benefit with colchicine, though there is some event reduction. So that's why perhaps it's not so popular with physicians, but it's in a borderline case, in a mid-range case, when there is patient is in the moderate risk, this is a game changer. Because in a moderate risk patient, if you have got a basal HSCRP high, you immediately put the patient into high risk. And all the targets, all the focus immediately change. So I think that is a bit of a niche role of HSCRP in today's practice.
Yeah. Thank you for the excellent comment. I think over to Ashwini. So one more question. See, how frequently one should monitor lipid levels and glycemic control in a patient with diabetes and dyslipidemia?
Yeah. So in fact, it depends on the control. So I would say that if the patient is reached the target and the patient is stable, say and the LDL targets have been met, then I'm not so keen to get it done very, very frequently. I did look at it earlier, and the recommendations were once in a year if you are stable, at least once in a year, at least. So, but if the levels have been fluctuating, you have not reached the target, the patient has not reached the target, then maybe it can be done earlier. And maybe at 6 weeks or 2 months, we can repeat the lipid profile, up titrate the dose. The idea is to get it there. And once the targets are reached, then you can breathe a little easy. And then maybe you can do it every 3 months, 6 months, or preferably at least once in a year. You must check the lipid of the patients who are on target. And I would say clearly, when I say who are on target, I like to look at both LDL and non-HDL cholesterol.
Okay. Another question is this one: in ACS or CABG patients, that is coronary artery bypass graft patients, there is an ongoing discussion about the optimal duration of dual antiplatelet therapy to prevent recurrent events. How do panelists navigate the balance between the benefits of extended DAPT and increased bleeding risk, especially in the context of patients receiving rosuvastatin? What factors should be considered when making decision? I think the question is clear. In the context of taking rosuvastatin, the benefits of DAPT, that is dual antiplatelet therapy, and increased bleeding risk, how do you manage? Sir, JPS, any thought about it?
I don't think there is an interaction between rosuvastatin and DAPT test. But yes, this is a question which comes to the mind of many physicians what to do in particularly post-CABG. For PCI, we know that dual antiplatelet has to be given for 1 year, and some of the trials are now coming with single also, with only giving ticagrelor. Those are the small trials which are there. But yes, they have suggested that those who are having high bleeding risk and less ischemic risk, probably you can give only for 3 months the dual, and then after that you can only continue with one single antiplatelet agent. But let's change the gear now, that for CABG patient, that is the area we are basically concerned. So if a CABG is done in a context of ACS population, then dual antiplatelet is to be given for 1 year. We prefer the clopidogrel and the aspirin in majority of the population. But if it is done in a stable CAD population with CABG, single antiplatelet may be good enough to be given in this population. So there is no need of that. And there is certainly no interaction between rosuvastatin. Yes, the statin should be continued with the goal of keeping it below 55 and with or without HMI. So that is same. The goal of CABG and PCI patient is not different because they are patient of CAD.
So
may I just interject, Dr. Pillai?
Okay, carry on.
Perhaps the bias of the question is that in the days of very high dose statin, there is possibility of plaque stabilization and plaque passivation. And with the newer techniques of angioplasty or bypass with better equipments, whether that role of dual antiplatelet remains for a long time, because we are treating the other confounding factors very tightly. But unfortunately, there is no such head-to-head trial that with the high dose of statin and low dose of statin, whether dual or single antiplatelet duration, you can really change. It's kind of anticipation that you might need a shorter duration, but there is no proof. But I think the idea is that with high dose statin, you are already treating the plaques. So why dual antiplatelet? I don't know. I don't have an answer.
Okay.
Yeah. Can I make a comment here? I'd like to say that there is no evidence today to suggest any change in the usual practice in view of whether using rosuvastatin or high dose statin. But what the point you made, Dr. Ray, is perfectly well taken. That could be the thought behind it. And also, there have been some studies suggesting rosuvastatin interfering with the platelet aggregability of certain molecules. But then that's too far-fetched and taking things in different context. As of today, there is no confusion.
Right now,
Dr. Ray said,
right now, there is no conclusive evidence or no confusion in the minds of the practicing physicians or the practicing healthcare professional that there is any interaction between negative interaction between rosuvastatin and DAPT or in the context of managing dyslipidemia. So shall we move on to the next question? This I will take up. Are there any genetic tests or markers that can help guide treatment decisions or predict response to therapies? So are there any genetic tests or markers that can help guide treatment decisions or predict response to therapies? I think if you're taking familial hypercholesterolemia, because I have done a study with around more than 150 patients, though there were some patients who are hypo-responders to statins, or especially those patients, their genetic receptor is LDL receptor negative. Those are called LDL receptor null or LDL receptor defective patients. These patients, LDL receptors are very marginal or very low, either 0 or less than 2 to 5%. So these patients won't respond to this thing, statins or even PCSK9 inhibitors. Their treatment is entirely different. Either it is LDL apheresis or evinacumab that is not available in our country. LDL apheresis is available in a very handful, I think 1 or 2 centers in India. And the second thing is that the ABCG5 or ABCG8 mutation, that is a cytosterolemia, that is better respond to ezetimibe rather than statins. So statins and ezetimibe will do wonders, especially in cytosterolemia. And in the case of simvastatin or statins, there's a genetic variation called SLCOB1 that is causing increased rhabdomyolysis. These things are very rare. That is the answer to, are there any genetic tests or markers that can help guide treatment decisions or predict response to therapies? So I'm going to the next question. How do you differentiate between true statin intolerance and other factors contributing to patient discomfort or adverse effects? Because most of these patients will complain myalgia and all. So who will take up this thing? Ashwini or
Savitra will like to take, because he has written chapter on that.
Okay.
Yeah. My chapter is on statin. Actually, that statin-related muscle symptom or SMS, 90% are nocebo effect because of media and other physicians. Even the physicians contribute to the nocebo effect. So firstly, if there is any muscle symptom, we must also look for muscle sign, whether there is real tenderness in the muscles. And if they are present, we must do a CPK test. Plus minus and aldolase. Aldolase is not so popular nowadays, but CPK is the standard test. If the CPK is high, more than 3 times normal, more than 5 times normal, then of course we have to take it seriously. We put it that it is due to statin, most probably, and there is muscle injury. If it is more than 10 times, it is serious. There could be rhabdomyolysis and there could be acute kidney injury. Now, in any case, we have to stop the statin temporarily. We have to stop the statin and see if the muscle symptoms, sign and CPK regress. If they regress, it is proof that it was due to statin. And if it was not initially very high, we can take different strategies. Like we can give a very small dose of the same statin, like say 5 milligram atorvastatin, or we can give it on alternate days or even twice a week. Or we can change the statin, say from rosuvastatin to pitavastatin 1 milligram. So these are the different strategies we can play with and see if their symptoms, sign and CPK rise recur. If they don't recur, that's fine. We can gradually up titrate, keeping a close eye. If necessary, we can add ezetimibe or bempedoic acid. If there is no symptom. But if the initial symptoms are, initial CPK was high, then we have to stop the statin for at least 6 weeks to 8 weeks. And then it's very difficult to start again or experiment with those. If the demand is very high, patient has ACS, a stent put in, a bypass with ACS, so on, then we have to do all those tricks like small dose, alternate day statin, a lower potency statin, and so on. But here, perhaps, we have to go for ezetimibe, bempedoic acid, and if necessary, the PCSK9 inhibitor and inclisiran. But mostly we have to also see the vitamin D level. It has been found that mild symptom signs can be alleviated if the deficient vitamin D can be corrected. Though we do not recommend a statin vitamin D combination, though there are some companies have got that, but we recommend the vitamin D assay. And if it is low, then it's better to correct it. That might cure some of the sign symptom. There are certain groups like elderly ladies with renal function problem, with rheumatoid arthritis. These are the patients who are more susceptible. And we have to also be careful about the drug interaction with statin, because we sometimes forget that statins have drug interaction which can cause muscle symptoms.
Yeah, Dr. Soumitra, let me interrupt. Dr. Soumitra, your video is not visible. Your hand is.
Right.
And
Yeah.
is
Okay.
something
Sorry,
that,
sorry.
Yeah,
So,
one more.
so I will add, Krishan, I will add the couple of points to previous question also, that hyporesponder to statin. I think what we have seen some of the patient, when we know we have to give high dose of statin like 80 Toro or 40 Rosua, but patient is not reducing to 50% what is expected, then we generally look for lipoprotein little a, because it has been seen that those who have got associated high LPA, the LDL present in LPA is generally not responding to statin. This is what we have seen. So that is one way. And the second thing, what we have seen recently, I have come across few young adults coming to me with their executive health checkup report, and they are either the carrier of Fetch or those who are themselves have significantly high LDL cholesterol, and we have put them on statin. And when they came to me with a health checkup report, now these days some of the laboratories are doing CPK as a part of health checkup. And what we found very interesting, that their CPK levels were very high, in 1,000 and when it's 800 or 900. And when I asked them, I said that they are taking statin. So immediately your reaction comes whether it is because of that. But then I asked them, are you gymming? So they said, yes, we go for gym for almost 1 to 1.5 hours. And vigorous gym, lot of weight training and all that. So I said, oh, stop this gymming for at least 15 days and repeat your CPK on statin. Don't stop statin. And what we found, tremendous reduction in CPK levels. So that becomes sometimes false signal that it is CPK induced, because they did not have any symptom of myalgia or anything. So that is also one of the learning which we have now, that probably always look for the history of gymming. And people, they also use a lot of proteins and BCAA, branch chain amino acid, also while taking the gym. So those things may be interfering with the statin or with the CPK levels in that. So that's what I thought I will just share with you.
Exactly what you said, that gymming, taking a lot of physical exertion, especially gym exercises now. Because I had a patient yesterday, his CPK was more than 3,000 or something. And liver enzymes were elevated. I said, don't go for gym. At least avoid the gym for at least a week and repeat this CPK. So, sir, the time is getting very close to 9:27 right now. So, I think I'm having a question about the CSI guidelines. So,
we have 5 minutes time is there with us.
Yeah.
About the guideline, if any question is there, are there any checklists that CSI recommends for management?
Is there?
Commandment checklist. I mean,
Well,
the recommendation is that while I think this is Dr. Samitara's chapter only, that one should look for LFT ideally, but there is no recommendation of CPK. And when follow-up also, it is basically the SGOT, SGPT may be done once after the first or second lipid profile. And then they suggested not to monitor it if it is normal, and mild increase is expected, which will be there. And secondly, if you're going to change the dose, increasing the dose or adding another drug, probably again after 6 to 8 weeks, you may recheck SGOT, SGPT, ALT, AST at that time. Otherwise, CPK should be done only once a patient complains of myalgia. And we have seen in our experience, majority of the patient of myalgia do not have high CPK levels. They may be having normal CPK levels. So that's what we have about the checklist. There's not much of any checklist for that. But yes, that is the way we should follow up these patients. And in our guideline, the adherence chapter was very well written by Dr. Ashwini. And that is a very important issue, which is a challenge to us in clinical practice. For reason unknown, physicians, they try to reduce the dose of statin. And then they forget to repeat the lipid profile to see whether the LDL or not. So that's what we want to say message to our colleagues, that if you're reducing the dose for not reason of myalgia or no reason of rising HbA1c or new onset of diabetes fear, because 40% population is atherogenic and they are having central truncal obesity. And what we have learned from Jupiter trial, those who developed new onset of diabetes, they were the people, those who are having metabolic syndrome, and which is a big number in our country. So we are definitely prone for new onset of diabetes, or at least going from the non-diabetic to impaired glucose tolerance stage. Probably you can reduce, but then repeat the lipid profile. And if it is still above 55, then bempedoic acid becomes a safer drug to be added because it do not interfere with the sugar levels, unlike the statin drugs. So that's where we can
Sonny, give one message to the audience as well as to me as well. After an ACS with your standard treatment, say your LDL came 30 or 25, will you reduce the statin dose?
That's we had. You remember when we were preparing our manuscript, we had a good discussion which went on for 6 months, and we could not come to conclusion because the data from the Western literature does not favor. They say you continue because TNT trial, all those trial, patients were on 5 to 6 year on high dose of statin. So the recommendation did not came, but yes, then we decided that if there is a symptom of side effect, or if there is a rising HbA1c, probably these are definitely two indications where we should. Individualized decision of a physician saying that the level have come to 10, 15 and patient's affordability is a problem, or you may be thinking patient may be getting side effect. If he reduces the dose here, we request them to recheck lipid again. If you're reducing, and if it is the levels are below 55, okay, you continue with low dose. Then no need of increasing the dose.
Absolutely.
Sir, one more question. What patient populations are suitable candidates for inclisiran therapy?
Percentage of the
what patient populations are suitable candidates for inclisiran therapy?
Yes, if you look at the acute coronary syndrome population, when we have some data for the country available now, what we found that high dose of statin and HMI is taking care of reaching goal of 85% and above. If you give together, if you give only high dose of statin, then if your baseline LDL is above 110, which we did a study in our hospital, if your baseline is above 110, and if you give only a high dose of statin, and at best 60% reach goal of below 55. But if you add HMI to this population, it comes to around 80 to 85% approximately. But if you add bempedoic acid, you can reach approximately 90 to 95. But what we have seen, patient of ACS with familial hypercholesterolemia, very high level of cholesterol, patient of ACS with very high level of LPA. These were the group of population where we found even combination of the drugs were not helping us to reach the goal of less than 55. So I will say, just experience-wise, that approximately 5% population will be requiring this injectable drugs to reach the goal by 3 months. And for that, between the two drugs, now we know that the advantage of one drug over the other.
So from next question, from when to start screening as prevalence of dyslipidemia is rising in younger population, including children? I think CSI has definitely said 18 years, but even below that, in younger population, will you suggest anything?
Yes, FH, if a case is FH, index cases turn out to be ACS with FH, or as such we have diagnosed FH. Then like today morning, I saw one patient, a young adult staying very near to my home, and he came with this LDL cholesterol of 291. And he just did an executive check and found 291. So by scoring of Dutch lipid clinical criteria, the score goes to 5 because LDL above 250 is 5, above 190 is 3. Then I asked him family history. He said, yes, his father had MI at the age of 59, although not very long, but he had a bypass. So we can give one more score to that. So it comes to 6 score. So 6 means it is a potential FH. So it is diagnosed as a FH population. So this young man, definitely I asked him how many children he has. He says he has got only one daughter, 9-year-old. So I said, you must get lipid profile for her because there is an autosomal dominant condition is there. There's good chance, 50% chance that she may be also suffering. So for such population, we have recommended that those who are any age their children, above the age 2 years, which is the recommendation now to go for lipid profile for this young child, 2 years old. And in my experience now, I'm talking about the heterozygous group, not the homozygous group. The heterozygous group index cases, and we looked into the genetic study and confirmed by genetic study. I've got now 19 children below the age of 16 years, which are in my follow-up. Those were on statin. And the youngest one is 6-year-old. You see, the father of this girl had MI at the age of 38. We did the stenting. His uncle died at 36. Grandfather died at 49. So the wife of my index patient, she was intelligent. She Googled everything and she did I asked you, a 6-year-old, I said, wait for another 1 or 2 years. She said, no, I'm getting it tomorrow morning, the lipid profile of my daughter. And you know, LDL came 239. And now a question came whether to put her on statin or not, because lifestyle is not going to work here. Nothing will work. We have to. So we put her on statin now. And she's on 5 milligram of rosuvastatin at the moment. And her LDL next we did after 4 weeks is 139. So there was a 100 milligram drop by even 5 milligram of rosuvastatin. The guideline says for children to keep it below 130, not 100. That's what the recommendation is. And now we have got a good paper from published in New England Journal of Medicine looking at the safety of statin in children. It's a 20 years follow-up and a wonderful paper, and which shows that there's no difference in the growth, in the sex development, puberty development, or everything. Nothing was made any difference. Rather, one small study from Scandinavian country did show there's those children, those who are on statin, they are showing a better growth. So we don't know, but anyway, there is no harmful effect of the statin in children.
Sir, we are overreaching the time target.
Yes.
Yeah. So the final, any message from these three, any panelists, one-liners? Dr. Ashwini, any one-liner message?
Yeah, in fact, I'd like to give my idea to all my physician friends who have joined that one, we have to start early, we have to hit it hard, and once you reach the goals, don't stop there. And if the LDL is very low, please don't stop or reduce the dose of statins. That is one single message, get it down. And then another thing, that any pretext, like a patient comes with mild body aches or anything, do not stop statins. Most of these complaints are not really related to statins. So very simple. I like to keep it screen early for all your patients. And the American Academy of Pediatric recommends 9 to 11 years is the time for screening in routine. But in high risk, like what Dr. Sani said, there is no limit of any age you can go ahead and screen. But once you've screened, follow the guidelines, treat them accordingly, get the lipid down, don't stop the statins. Statin intolerance is there, but then it's very, very rare. The real intolerance is very, very rare.
Dr. Soumitra, one single one-liner, because time is...
Just one liner is that random sample is good enough, and do the sample. Don't put it down for age of 60. So first sample, random, as early as possible in your lifetime with an LPA. That is my single message.
Sir, finally, finishing with Dr. JPS.
You see, my one-liner is that please read the guidelines. It is available online at the moment, and we are trying copy also to everyone, at least executive summary to each and every physician. If your online is already available now, but physical copy will be coming to each and every physician in the country soon, within next 1 or 2 months.
So before signing off or saying Alvida, I'm handing over to Om Prakash for a vote of thanks.
Very good evening, sir. I am Om Prakash. I think, sir, on this occasion of National Lipid Day, JB salutes to each and every healthcare physician and cardiologist, for keeping the heart beating for the nation. I think that's very important, sir. And thank you very much for the very, very, exclusive talk on familial hypercholesterolemia. I think all the to benefit with this. And at the outset, I also want to extend regards from JB Pharma and thank you for giving us opportunity to get associated with Familial Hypercholesterolemia Research Foundation. Special thanks to all of you, sir. Dr. Sahani sir, Dr. Krishna Kumar sir, and Dr. Ashwini sir, and Dr. Soumitra Ray sir. Thank you very much for helping us to be partner towards effective scientific programs, sir. And at the other end, sir, definitely would like to extend thanks to 1,000+ HCPs who have been there with us, for 1.5 hours and making this event successful. And at the end, sir, I would also like to thank to entire my team members also who made it a successful event for us. And thank you so much once again to all of you, sir. Thank you.
Oh, thank you, Sarita. Thank you all.
Thank you,
Thank you all the
Jaydeep.
listeners.
Thank you,
Thank
Kumar.
you. Thank you. Thank you.